in Yogyakarta. And we already have Dr. Stephen in this webinar room. Okay, let us start this webinar. Good morning, everyone, and good afternoon to Dr. Stephen. Hello, Dr. Stephen.
Halo, selamat siang.
Okay, selamat siang, Dr. Stephen. Okay, so we already at 10 a.m. and it's now time to start this webinar. Okay, and currently we are still waiting for the participant to join. Okay, so before I start this webinar, first of all, I will explain about the flow of this webinar. So the webinar will be started by the first one is opening, and then we will have the reading about the flow of the webinar, and then about the CV from Dr. Stephen, and then after that, we will go to the main agenda, which is presentation from Dr. Stephen about advancing learning and research on field epidemiology investigation into urban health emergency. And then after that, around 11 past 20, we will have a discussion session, question and answer for around 30 minutes. And then after that, 11 past 50, we will have a summary and closing. Okay, so let's start by opening this webinar. Good morning, everyone. Good morning, Dr. Stephen, and good morning, the UGM teams. Today, we will have a webinar regarding the urban health epidemiology. This is a new terms for us in Indonesia and Jakarta. And then today we will learn about this approach of urban health epidemiology and urban health emergency, and how this related with the field epidemiology investigation, and what is the experience in Singapore. So for today's webinar, we will have our Dr. Stephen as the speakers for this webinar. So Dr. Stephen is a senior consultant in National Center for Infectious Disease and also the director for the Singapore Field Epidemiology Training Program in the National University of Singapore. Okay, and let us greet together. Welcome, Dr. Stephen, in this webinar, and welcome everyone. So we need a little bit information about Dr. Stephen because the curriculum vitae is quite long. Dr. Stephen is a senior in this field. So Dr. Stephen is from Singapore and has a qualification about public health and Master of Public Health from National University of Singapore and also Johns Hopkins University. Dr. Stephen is also a fellow from the Academy of Medicine, and its specialty is public health medicine, with the field of interest is field epidemiology, environmental public health, outbreak management, urban health security, and emerging infectious disease. And currently, as I mentioned before, Dr. Stephen is a senior consultant and infectious disease research and training office, and also as a adjunct associate professor in National University of Singapore School of Public Health, and also currently a program director and coordinator of Singapore Field Epidemiology Training Program. For the information, in Universitas Gadjah Mada, we also have a Field Epidemiology Training Program, and there is around 7 FETP Field Epidemiology Training Program in Indonesia. And then the last one is as Associate Program Director in National University of Health System, I think, and it's as Preventive Medicine Residency Program. Dr. Stephen also has many experience as in international organization as a member of advisory boards. TEVINET is the international organization that manage the whole field epidemiology training program in around the world. And Dr. Stephen is elected as a representative of ASEAN +3 and Western Pacific regional countries. Dr. Stephen also was a technical advisory group panelist to WHO, FAO, and WOHA and UNEP from the 2021 and 2023. And also as a trainer on applied epidemiology and rapid response in Singapore, and also chair and editorial committee for infectious disease intelligence until 2024. And there is also experience on teaching. Dr. Stephen was an adjunct lecturer in University of Newcastle until 2009, and also in Singhal Family Medicine Residency Program until 2019. The experience related with the publications, there is quite a lot of papers, and I will only mention the recent one. It's about the Singapore effort to achieve measles elimination. And then there is also paper regarding whole genome sequencing of the rare Salmonella enterica serova isolated from food handlers. Yes, and I think that's all from my side about the curriculum vitae of our speakers today. So without further ado, maybe we can go into the session, the next session, which is a lecture session from Dr. Stephen. So Dr. Stephen, are you ready to present your
Terima kasih,
lecture?
Dr. Bayu. I will
Okay.
now share the slides, if I may.
Yes, you can, Dr. Stephen.
Okay. I hope everyone can see the slides.
Yes, we can see it, Dr.
Okay.
Stephen.
Thank you for this invitation to Universitas Gadjah Mada to share on advancing learning and research into field epidemiology investigation. And the theme here is urban health emergencies. We want to share a little bit about this emerging new field of urban epidemiology practice. And this is something that I think the whole world is going to be interested in, because the urbanization process in the world is taking place. And I read with interest that in Indonesia today, about 56% of the population is already living in the urban centers. And you have large urban centers like Jakarta, the greater Yogyakarta area, Surabaya, Bandung, and so on. So I think there will be certain interest and in the unique features of urban epidemiology practice. And by 2050, the WHO expects that 2/3 of the world population will be living in urban centers. Okay, why do urban settings increase our risk for health emergencies? We are familiar with pandemic COVID, and with in the past had also pandemic H1N1. There is certain epidemiology that is happening now that we see, something to do with zoonotic spillovers that come out of the ecosystem through animals. They are able to mutate and jump species from animal reservoir to the human, and then because of certain transmissibility factors, especially in urban setting, they can then spread very rapidly, first within the hospital and then into the community, and very quickly across to other cities and other countries. So this is the key concern about urban settings. Jakarta, for example, is linked to Singapore by air travel, several flights daily. So this is something that we share in common. And similarly with all the other cities in ASEAN, Bangkok, Kuala Lumpur, and so on. So there is a common interest to safeguard the public health of the entire region. And Singapore has produced with the WHO, World Health Organization, this document on advancing health emergency preparedness in cities and urban settings in COVID and beyond. And it is downloadable from the WHO website in PDF form. I would encourage interested parties to access this website and download the publication. May I now share some of the urban epidemiology practice experiences that Singapore has gone through. As you know, we are a city state and we are highly urbanized. There are 6 million population in a very small area. And we are also very dependent on food import and trade and travel and tourism. So we are porous, and every risk in the emerging in the region as well as worldwide can also pose a threat to Singapore. I now share with you some of the classic outbreaks that have given rise to policy review in Singapore, starting with Nipah in 1999. This was a brand new emerging virus that came out of the animals. And today we know this virus as a Nipah virus. Is a new category that was a result of certain interesting phenomenon in Malaysia early that year, where we believe that there was a change in the farming practices that gave rise to the bats, which are a natural reservoir of the Nipah virus, coming out of their caves and feeding in the farms in the Perak state. And it was through this contamination that the pigs, which were also being farmed in these plantations, became infected. The original diagnosis was Japanese encephalitis, which was a wrong diagnosis that complicated the management and prevention and control. Later, there was also environmental mismanagement, and the zoonotic spillover spread to the southern states in Malaysia, Seremban, near the Nipah River, where the virus is named after. And then subsequently, because we imported the livestock from Malaysia, it also entered into Singapore. So this was a very hard lesson for us. And there were many things that we can discuss in this issue. But one of the key concerns was the misdiagnosis of Japanese encephalitis, highlighted the importance of having accurate diagnostic process for emerging infectious disease. Moving on, in the year 2000, Singapore was hit by a spate of deaths involving very young children, preschool children. And in October 2000, we had 4 children that died, and the etiologic agent was established to be this virus called the enterovirus A71. A71 enterovirus is a common cause of hand-foot-mouth disease. So this spate of fatalities occurred amidst epidemic of hand-foot-mouth disease that was occurring in Singapore. The autopsy of the cases identified EV71 in several tissues involving the brain, the heart, and the lungs. And this was a very unique case of enterovirus A71 infection, giving rise to meningoencephalitis, fatal myocarditis, and pneumonitis. The lessons here were related to how to manage childcare centers. A lot of Singaporeans, because both husband and wife, they work, they have to send their children who are very young into a preschool setting. And even as early as 1 year or 2 years old, they would be entering a preschool setting. And the concern here was that this enterovirus was a common source of infection within such settings. And so there were need to step up a lot of hygiene, sanitation, and control measures with respect to the regulation of these preschool centers. Then a few years later, we were hit by SARS. Singapore was the epicenter together with Hong Kong for the severe acute respiratory syndrome. And again, this one caught Singapore unprepared. We were assuming that our hospitals, including the main hospital, Tan Tock Seng Hospital, had sufficient infection control. But when this atypical pneumonia came into Singapore, it was shown to be inadequate, and so it spread within the hospital. And one observation of coronavirus is that there is a phenomenon called super spreading event, where one person can spread to over 10 people. And such super spreading events were actually could account for the entire outbreak in Singapore, where there were 5 such events, okay, that spread over 3 months until the disease was controlled in June, July of 2003. It was also during SARS that Singapore developed its contact tracing procedures, because this was a droplet-borne disease that was new to the world and there were no quarantine facilities available. We therefore had to think very hard and make a trade-off to develop the home quarantine order, where people who were suspected to have been exposed to a contact, okay, had to be issued a quarantine order and forced to stay at home and enforced to stay at home, so that over a period of incubation, they could be watched to see that they do not develop symptoms and spread to other people. This contact tracing capability served us well later when the H1N1 hit Singapore in 2009, and subsequently also in the COVID pandemic recently. Okay, besides these emerging viruses, there are also a lot of outbreaks in urban setting that are related to urban lifestyle, okay, modern lifestyles. And one of them here I would like to highlight is an outbreak of a fungus known as Fusarium. Fusariosis is the name of the disease, and it was an outbreak that was caused by the use of contact lens lotion, okay, the Bausch and Lomb Renew lotion, which was used by many Singaporeans, had actually a flaw which we had identified first in Singapore and then subsequently elsewhere in the world. And we worked with the pharmaceutical agency to withdraw this product, and following a very thorough case control investigation of all the cases that had arisen in Singapore. It is a fungus that can cause loss of sight. Typically, it causes a keratoconjunctivitis, and it enters the eye with a tear on the surface cornea. It grows in the cornea, and if it gets very bad, it can penetrate the back of the cornea into the anterior chamber, and here is where permanent loss of sight could result. Then in 2008, Singapore again realized another emerging infectious disease, which was chikungunya. Chikungunya is an African term, a Nakonde word for that which bends, which is a very painful manifestation of a joint problem in this disease. We did not know, but because we have a very good AIDS control program in Singapore, we assumed that we would not have any problems with imported infections involving the Aedes vector. Actually, now with hindsight, we realize that this disease had spread from Africa into South Asia. Firstly, it had swept through India and neighboring countries. And then with our guest worker population, which we depended on very much from these South Asian countries, they had come to Singapore. They brought the virus together with them. And the first outbreak in Singapore was in Little India. And it was again a wake-up call, because there was inadequate vector control in the premises of these guest workers. There were 2 waves to chikungunya in that year. The first wave involved Little India, but there was a subsequent wave which was quite surprising to us, again related to urban modern lifestyle practice. And this was in the second half of that year, when a lot of Singaporeans came down with chikungunya after they had traveled to Malaysia. And why did they travel to Malaysia? Because there was a durian tour promotion that was going on in that period of time, where Singaporeans were attracted to visit Malaysia over the weekend and eat as much durian as they can from the durian plantations. So this was very popular, and as a result, many Singaporeans on Saturday and Sunday, they went to the southern state of Johor for these durians, but they were unfortunately also bitten by infective mosquitoes, and they came back with chikungunya. Foodborne disease is always a problem, especially when we live in the tropics, and hygiene, sanitation is always a key concern. There was, in the year 2009, a severe outbreak involving Vibrio parahemolyticus, which caused 2 fatalities in Singapore. This is unusual because our food poisoning tends to be self-limiting, even our massive outbreaks, but this one caused 2 fatalities, which suggested either virulence of the organism, or else it was a high infective dose that had occurred. Following this, also, there was a stepping up of the measures that were taken in our hawker centers to improve the food handling and environmental hygiene practices. In 2012, there was an international rugby tournament in Singapore involving Australia, Hong Kong, Singapore, and Middle Eastern country. And during this tournament, there was a severe rainstorm that had occurred that rendered the field extremely muddy. And it was a few weeks after the event that the Hong Kong authorities informed Singapore that they were seeing a spate of keratitis, sore eye problems amongst young residents who had just returned from a rugby tournament in Singapore. So that sparked an international investigation, and the etiologic agent was identified to be Microsporidium, another fungus, which is an environmental bacteria, fungus. And this can be found in the field, the pitch in the where this tournament was held, and it was very likely that because of all the rolling and contact, including eye exposure, Microsporidium had entered into the conjunctival and given rise to this problem. So again, another outbreak related to lifestyle practices. 2015 saw what was the worst outbreak of Group B streptococcal infection in Singapore. There was a spate of cases that had eaten raw fish, okay, from a very famous Chinese porridge stall in Chinatown, and subsequently came down with all kinds of abscess in the brain, in the joints, and with even gangrene of the extremities. Investigations were initiated, but it was not a notifiable disease. So we had to get the labs to do a look back for the past 5 years to see the incidence of this GBS and their isolates. And to our horror, we found that this condition had started to go up as early as 6 months prior to the alert. And there was an immediate epidemiologic investigation that identified the source of the Group B streptococcus as traced to a certain type of fish, songfish, which was imported from a neighboring country, and they had been brought into Singapore without the proper hygiene and cold chain checks and balances. So this was again another eye-opener for Singapore. 2016 saw our Zika outbreak, a massive one in the Aljunied area in Singapore. And again, there were guest workers who had acquired the infection, but because they were not monitored so tightly, they had gone on to continue working despite having some symptoms. And this gave rise to the spread of the Zika infection into the premises in the surrounding residencies. So again, another lesson for us that we need to monitor vulnerable groups. So all this leads us into this understanding that there are many emerging infectious diseases that can occur in urban settings that can occur at the interface between the humans, the animals, and the ecosystem. And with climate change as well, I think these problems will increase. So fast forward now to 2020, where the whole region was swept up with this COVID-19, another coronavirus, also a zoonotic infection. And this was a surprise because everyone here thought that the coronavirus would disappear, just like SARS after a few months, but it did not disappear even after 3 years. So today we have now learned the concerns about trade-offs in public health between acute breaking the chain of transmission and the long-term consequences to such actions. So I will elaborate a little bit about these things later in the talk. So were mistakes made? Yes. Were there weaknesses? Obviously. And Singapore has published a white paper on the Singapore experience of COVID-19. It is downloadable from the Ministry of Health Singapore website. You can take a read. There are quite a number of things which we admit we have done wrong. And so I think those are the important parts that we should read, because that is where the lessons can be learned. Now, we need to advance learning and research in field epidemiologic investigation. And here I would just share with you a little bit about the evolution of the field epidemiology training program. You know, the FETP was established by the US Centers for Disease Control, modeled after their Epidemic Intelligence Service, which was started in 1951. In 1980, they made their first FETP abroad in Thailand. And that time, the concerns were like HIV, Ebola, and Nipah. And the CDC said, this is what we train our epidemiologists on. Can you try this on for SARS? So the FETP, which was a 2-year program modeled on the EIS, was applied in that respect. But as you know, the whole world, there are many different contexts, and Southeast Asia is not the same as the United States. So very quickly, after a decade or two, we learned that things need to change a little bit. So with the complexity, we needed to collaborate. So in 2000s, when we had our SARS, we had our H5N1 and H1N1 influenza, we started to form certain networks like TEFINET and GOAN, okay, the Global Outbreak Alert and Response Network. And we also had the One Health movement startup, okay? And at the same time, the international health regulation was also revised, and the new one adopted by the World Health Assembly. And there were the startings of the networking that FETPs have that we enjoy today. In the 2010s, new diseases started coming out, like the MERS, the Middle East Respiratory Syndrome, Zika, and other emerging infections. And here, things were getting more complicated, and the need to customize FETPs became evident. So it was during this period that we had this FETPV, the Field Epi Training Program for Veterinarians, FELTP, the Field Epi Training for Laboratorians. Okay, we had frontline FETP, intermediate FETP, and it was also at this same time that the ASEAN region, we benefited from the establishment of 2 regional networks in field epidemiology. The first was the ASEAN +3 Field Epi Training Network, and Indonesia is also very much active member in this respect. And the second one was SafetyNet. Okay, the ASEAN +3 FETN is based in Bangkok, while the SafetyNet is based in Manila. Today, in 2020s, we have experienced COVID-19, Mpox, and there is the imminent disease X, okay? and things are turning a little bit more chaotic with the geopolitical situation. So we realize that FETPs must also change. And so we must upskill for our survival. And here we have already the WHO together with the FAO, the WOAH, the WOA, as well as the UNEP to come up with the competencies for One Health Field Epidemiology framework, which is a series of documentation that shows the curriculum that needs to evolve to embrace the not just human health, but also animal and ecosystem. Okay, there's also the GFEP, the Global Field Epidemiology Partnership, which is just recently launched by WHO and the US CDC. And this one is also trying to be a platform where all the FETPs can come together, share experience, and also learn from one another. Okay, why do we need all this upskilling? It's because urban health emergencies are going to become a lot more difficult in the future. There's also global fragmentation trends that are happening. And there's also a big problem with the politicization of public health. This pandemic COVID showed us that many countries, the decisions made were political rather than public health professional. And there's also many important stakeholders with a lot of money that can fight public health. So we need to be aware of these, how to engage such stakeholders. And social media has also done its impact. There's a lot of disinformation and misinformation out there, leading to distrustful populations. And if these vulnerable populations do not agree to to comply with measures like quarantine or vaccination, then this will again result in a breakdown in the public health measures. So we need to upskill ourselves. And this is where Singapore is offering next generation or next gen FETP to the world. So let me just give you a little flavor in the short time we have about the next gen FETP training that we do. In the EIS program, I think trainees learn about the 10 steps in outbreak investigation or the 12 steps of outbreak investigation. I here summarize for all of you the ABC of outbreak management, which is just 3 steps, okay? So in effect, if you do these 3 steps, you will remember all the 12 or 10 steps that are enumerated. What is the first step? A is to assess the situation, all right? And when you assess the situation, you actually ask 3 questions, which are the classic questions in epidemiology. Who, where, when. This is person, place, and time. You ask these 3 because they are all necessary to triangulate and identify the vulnerable population, which is at risk in this particular health emergency. So this is also known as descriptive epidemiology. And by answering the who, where, when, you are able then to define the area and the actions that are required. So contrary to popular belief, it is not so easy to actually start an outbreak. You must fulfill at least 3 conditions, okay, for an outbreak to occur. Firstly, there must be a new pathogen that is introduced into a group of people. Secondly, this group of people must be susceptible with an adequate number of them not having resistance to this new pathogen. And thirdly, and most importantly, there must be an effective means of transmission of the pathogen, okay, to the susceptible host. So the environment is a very critical component in this, and this is also known as the epidemiologic triad. You are familiar, those who have done outbreak before, with the simple outbreak charts, which we call epidemic curves. An epidemic curve plots person and time, okay? If you want to plot person and place, then we call it a spot map. So in an epidemic curve, it gives you valuable information about what is going on out in the community where the health emergency is happening. And the most classic simple one is what we call a point source outbreak. A point source outbreak has a very sharp rise and a sharp decline, showing that it is self-limiting. And if you observe the day of onset of illness, the first day and the last day would fall within the typical known textbook incubation period of the pathogen. So it's very important to obtain biological samples, stool sample, for example, or blood sample, to establish the etiologic agent, for which you then know the incubation period and whether this would be a point source outbreak. If it's a point source, you are less worried because it is self-limiting, and your investigation would likely trace the source of the infection to an event such as a wedding ceremony or a sports day or something similar, okay, which is over. Now, what is more complicated would be what we call a common source outbreak. And in this case, in Singapore, it was a paratyphoid outbreak that spread out over a 5-month period, okay? So it is a epidemic curve that looks a bit similar, but if you look at the length of the outbreak, it is definitely beyond the known incubation period of any pathogen. So this one suggests that there is an ongoing source of infection in the community. And indeed, this one, when we investigated, eventually we traced it to a stealth agent, okay? It was actually coconut that had been contaminated, imported into Singapore, and it was used in several types of dishes, coconut-based, and therefore it was not possible to identify one implicated agent. Rather, it was all the different food items that had used coconut. So that was why it took so long for us to establish and eventually break the chain of transmission. A bit different from the common source outbreak is a propagative outbreak. And this outbreak characteristically is one that is spread by droplets from person to person. In an age of pandemics today, droplet-borne person-to-person spread is something that all of us as practitioners must be very familiar with. And one of the classic characteristic of such an outbreak is that early on in the epidemic curve, you will see a consistent, okay, periodicity to the cases. So in this case, you can see in the first wave, second wave, third wave, the generations, there is a break, and this break represents the incubation period of the etiologic agent. So over time, when the control, if it is unsuccessful, the periodicity merges because one person may get it from multiple possible sources. And so as you can see, it starts to lose that break intermittency in the epidemic curve, and then it can all merge together and show as the one big outbreak. Now, it's not enough just to look at outbreaks from the scientific point of view. There is also a security concern. And today, there is a lot of what we call terrorists who are seeking attention and may actually use either bacteria or any other microbial agent or even chemicals, okay, to contaminate water, air, food, and give rise to very severe health emergencies, all right? These terrorists are not necessarily organized by ideologic groups, but they can also be disgruntled staff of certain companies which have access to these chemicals or biologicals. And they may just do it because they wanted to discredit their company or because they have a bone to pick with society. So we have to be very careful today. Whenever there is something suspicious in our investigation, we have to flag up the security agencies. And today, Singapore Public Health, we work very closely with the police, CID, and we alert them when there is involvement of suspicious findings. This is necessary because in our experience, we've had 1 or 2 such outbreaks which actually turned out to be deliberate contamination that had occurred. Okay, so now you know A is for assessment, assess the situation. Now we go to B. B is to break the transmission, okay? So having assessed and you have asked 3 questions, now you must ask 2 more questions. And the 2 questions are why and how. These 2 will help you identify what is the source of infection and the mode of transmission. And this why and how you will apply when you do analytical epidemiology, okay? So from descriptive epidemiology, we move into the area of analytical epidemiology, where you make inferences. And one of the tools that you use here will be the case control approach, okay? A case control study is a very common, easy to use tool in public health, where you assess after a case definition, you assess the exposure to certain risk factors, compare it between the cases and those who are not affected, known as controls. And so you will be able to establish the significance of certain exposure risk factors, whether they are statistically significant, and if they are so, whether they are causal in nature. That will be the next step. So breaking the chain of transmission is something that you will be always at the back of your mind when you do analytical epidemiology. Here, I would like to share with you a real outbreak that had occurred in Singapore. It was a cholera outbreak, and as most of us in practice know, most of the severe outbreaks occur on Friday afternoon. Now, there were 8 cases laboratory confirmed with Vibrio cholera infection, okay? And that was all we had to go on a Friday afternoon. We had not investigated the cases. We only have the notifications which were required by law to be sent in by the laboratory. So what do you do? Amongst practitioners, there will be one group that says, we must alert the public immediately. That means on the Friday afternoon, we must prepare a press release. But there will be another group who will say that, no, let us investigate first, because if we do not know where this source of infection and mode of transmission is, just releasing the information will cause panic in the public. So which group will you belong to? Long story short, I would suggest that you should belong to the first group that must release the information to the public as soon as possible, that is on a Friday evening. Even though you have not investigated, and there are ways to release this information just factually without having to hazard a guess, because there is risk of ongoing transmission. And here we apply what we call the precautionary principle. The precautionary principle states that if there is a risk of ongoing transmission, you must err on the side of caution, and therefore you must protect the public in case there is a risk that they might be infected. So this was exactly what the Singapore government did. Ministry of Health on Friday evening alerted the media. It was taken up, and the Saturday morning, it was headline news that 8 ill with cholera bedok stalls suspected. Now, it was not the Ministry of Health that said it was bedok. It was the reporters themselves that had used the information and decided that it was bedok stalls that would be the source of the infection. What did we do? We had just said that we have been alerted to 8 cases of confirmed cholera and that investigations were in progress. Then they would ask, where do they stay? And we had to release factually that majority of the cases has stayed in the bedok area. But we didn't say that it was caused by bedok stalls. It was the own journalists who decided that this was the best headline, and so they sensationalized it. Immediately, there was a lot of public outcry, and there was also panic, okay? And that was to be expected. And ministry just has to do the right thing. We have protected members of the public from innocently consuming food items that potentially may have the cholera pathogen, but it had caused businesses to lose a lot of their customers over the weekend. So they were up in arms, and of course, when they have this kind of issues with the ministry, they will complain to their member of parliament, and the member of parliament will then bring it up to the minister. So there was a lot of this sideshow involved during this outbreak. But we were clear on the precautionary principle, and therefore we justified what we did. Imagine if we did not investigate and release the information on Friday, and then on Monday, instead of 8 cases, there are 100 cases. There will be the same journalists who will ask, Ministry, when did you first learn of this outbreak? And if you then give the fact that you had heard about it on Friday evening and did not alert the public until Monday, there will also be many heads that will have to roll. So this is the trade-offs that occur in public health practice. You must be clear, you must act on moral grounds with the community's interests at heart. Okay, here I will show you the epidemic curve that we constructed for 10 cholera cases that were identified during that period. And here there's a trick that I would like to show you. Cholera incubation period is half a day to 5 days. If you take the last case on the 10th of October and you put in the longest incubation period, okay? And then you take the first case onset of illness on 3rd October and you put in the shortest incubation period, then you will establish a window period of exposure that is over 4 days, okay? And for foodborne disease, you do not have to worry. It's a tool that we use because we understand that there can be remnant food that is kept in the refrigerator and consumed on a subsequent day. So what this tells us was that there was something that happened, an event, most likely in the Bedok area on the 2nd of October. And this had given rise to the exposure to the Vibrio cholera that had caused the cases. Some of the cases developed onset of illness later because whatever foodborne item they had purchased or been exposed to, they did not consume until possibly even until the 5th of October, the Tuesday, okay? This is the other tool that we use in field epidemiology, which is the spot map. The spot map provides us a very rapid view of the person and place variables, okay? And you can see why we hesitated to say that it's Bedok stalls, although you could see that majority of the cases occurred in the eastern part of Singapore. If you involve the 2 cases in Tampines, then the 5 in Bedok plus 2 in Tampines, strongly suggested that there was something going on in the eastern part of the country. The urban lifestyle practice in Singapore is that actually many Singaporeans, they do not limit themselves to food sources in their region. They will travel long distances to eat very good food from certain famous hawker stalls. So it is also plausible that the one staying at Bukit Panjang, Ang Mo Kio, and Hougang had gone to Bedok or Tampines over the period that is implicated. When we went down to the food history of each case of cholera, we tried to establish the 5-day food history. We recognized that there was no one common implicated premises or food stall or food source. So this was a big disappointment to us because everyone gave different addresses where they had frequented. And so when we plotted our spot map, we could not establish any particular pattern in the retail establishments. Nonetheless, negative findings are also considered findings. So here is another one. We looked at the case control study, and when we applied the case control approach, we had listed over 100 food items. And this is just a summary of the positive findings. We established that there was a statistically significant association between cases and their consumption over that period of fish, prawn, and squid, but not shellfish, okay? Now, this is very confusing because if fish, prawn, and squid are all significant, then which one is it? Is it prawn or is it fish or is it squid? Look at the p-value and you may get an indication that the prawn was much more significant than the fish and the squid. But nonetheless, fish and squid were equally statistically significant. So this was a clue again. And I think in epidemiology practice, you must never dismiss any clues that occur. Even negative findings are considered findings. So the first question we would ask is that if we look at the food chain, could it be at the wholesale supply? Because Singapore depends on fishery imports at our wholesale fishery port in Jurong. It was unlikely, because if something had occurred at this point, the outbreak would have been nationwide, but we did not see that pattern in the cases. So then the next question was, could it then have occurred at the retail level? And again, the answer was no, because based on our spot maps, there was no one implicated wet market or food center that had all the cases. So if it was not at the wholesale and it was not at the retail, where could it be? And that was where the hypothesis led us to the middleman. You see, there are middlemen in Singapore who buy the items from the fishery port and they transport it to their customers in different parts of Singapore. And it is very likely during that period of time that one middleman that supplied the Bedok area had bought the contaminated seafood, okay, had put all this seafood together with other types of seafood in his ice boxes, and then these ice boxes were shipped to the Bedok area where he had distributed it to various retail outlets. So this is indeed something that we highlighted to the Food Authority, and we asked, was there any regulation besides the wholesale and retail of the middleman? And we found out that there was no regulation involved in involving the middleman. So after this outbreak, in fact, the middleman regulation became also important to ensure that they carried the raw fish and other seafoods in very good hygienic settings. So break the chain of transmission. I think for different diseases, you will have different approaches involving the agent, the reservoir, port of exit, means of transmission, the port of entry, and the susceptible host. And I won't go into details. You can always Google these. But as a principle, this is very important for analytical epidemiology, leads to breaking the chain of transmission. Now comes the C. C stands for communicate the risk. Okay, so by communicating the risk, we are now alerting members of the public as well as our stakeholders on our findings, the implications of these findings, and so what can be done, not just by the authority, but also by themselves. Here, there are 3 questions I will also ask. And the questions are so what? And so what now? Okay, the question so sounds very short and sometimes very confusing. But let me expand it. When someone asks you so, especially if your boss asks you so, what he means is, why are you telling me this? All right. So you better get your answer ready if you are meeting the big bosses and you have a reason why you are telling him this. So it's the first entry into communication. And if you survive this, the next question that your boss may ask you is, so what? Let me translate. So what means, now that you have told me this, give me the implications of what you have just said. Okay, so you have to give him all the implications that you can think of. And if you survive that again, the next question that your boss will ask is, so what now? And the translation is, with all these implications, what do you recommend we do about it? Or what are you already doing about it? So what are the measures that you need to undertake with immediate effect? So with these 3 questions, you move into the area of what we call interventional epidemiology. Can you see that we have moved from descriptive to analytical to interventional? And here, interventions are very important part and parcel of the success of field investigation. There are many unique aspects to field epidemiology investigation. When we enter into the community to investigate an outbreak, typically, there are 3 things going on at the same time. The first is anxiety, okay? anxiety because people do not have answers and they are concerned about the risk to themselves. Then there is uncertainty. They have a lot of things going on in their minds and they're uncertain as to the outcome. It will impact their lifestyle. It will impact their families. So this uncertainty also needs to be addressed. And the third one is urgency. They cannot keep their lives on hold forever. So you as the field practitioner needs to be very timely and accurate in your actions. So with this, let me share with you some of the unique aspects of field epidemiology. The problem is often unexpected and the timely actions are demanded. Data sources are always limited because after the event, you may not be able to find the remnant food, you may not be able to find the implicated agents, the vector may also not be present. And the field investigator arrives after the fact and considerable publicity is already generated. Some of this publicity may be actually adverse to the investigation because of misinformation and disinformation. And there are conflicting pressures to intervene. There's always a group of stakeholders that will oppose you. For example, in the cholera outbreak, there were the hawkers as well as the politicians that were resistant to the Ministry of Health's efforts. Okay, this is a famous dish in Singapore known as katong laksa. And katong laksa is a very popular type of laksa in Singapore. It uses cockles, which are a very common type of shellfish in Singapore. It's quite succulent. And this is the preparation of the cockles after they've been deshelled. And really, you don't want to know from where the cockles came. So this is a big problem. Most of what we see in front of an eating establishment is very delicious. But when we go into the back area to prepare, we usually find that there are lapses in the hygiene and sanitation. So with time, we have had outbreaks of hepatitis A traced to consumption of these cockles. And when this thing happens, okay, and this is a tea-colored urine that's classic with jaundice patients, people will ask, how come I came down with the disease, but my friend, he ate the cockle, he did not come down with disease? So here, as an epidemiologist, and you understanding the science, you understand symptoms and constitutional reactions, you cannot use all this jargon to throw it to the public, okay? You need to digest it yourself and use simple language. So how to communicate? Do not aim for zero fear, okay? This is one common thing that a lot of public health rookies will start to say, don't worry. That actually does the opposite, all right? You must acknowledge uncertainty and err on the alarming side. So if you see that people are worried, acknowledge their worry and say that investigations are in progress. We will take all the precautions in the meantime. Be careful with risk comparison. Don't dismiss the concerns that they have. Tell people what you have done. Tell people what to expect and offer people things to do. So these are very simple guidelines that you would not go wrong if you apply them whenever you have an outbreak or health emergency to deal with. The question that was asked, why do some and not others get ill? There can be a lot of discussion about exposure, pathological process, and clinical illness. Please do not go there, okay? People do not, in a time of an emergency, want to know how clever you and I are. No, they want to know what are we doing to safeguard their health. So therefore, all these sub-factors about behavioral, immune response, genetic susceptibility, virulence, all throw out, okay? Do not use these words, okay? Because these are not important in the eyes of the public that we serve. Okay, similarly, for agent characteristics, it's pathogenicity, immunogenicity, virulence. In fact, these words are lost when in a health emergency, people just want simple, and very likely, if you do this, you might even get complaints about you whilst you are still out there investigating and protecting the public. So, deeper lessons in the art of communication. We have to build and sustain trust. If in peacetime, we don't talk to the community, and in an outbreak, we start talking to the community, there is no way the community will trust us. So we need to have avenues of communication and relationship building in peacetime so that when it comes to an outbreak, when we speak, the public knows who we are, understands that we mean well, and are able to trust us. Okay. We also have to beat rumors. If we do not respond to rumors, the public, especially the more suspicious people, will think that they are true, and therefore we don't respond. We need to quickly beat down any rumors, okay, and be candid and open. In others, we acknowledge any dangers, and we must contextualize the issues, okay? So this involves obviously not just a once-off press release. It will need dialogue. And if you have a health emergency that is protracted, dragging on for several weeks, you will need to have this process of feedback and dialogue, possible series of press conferences, press release, so that you can assuage all the concerns that the public may have from time to time. You also need to coordinate all the voices of authority. And this is where the One Health approach is very helpful. Often when it is a zoonotic spillover, there will be not just the Ministry of Health, but also the Ministry of Agriculture or Trade involved. And you need to have a joint release. Otherwise, you will be seen as not credible. A lot of intra-government discussion will then be aired as dirty linen, and it is not good for the public trust. Demonstrate action and progress. People need to see you at work and help people to help themselves. They also need to have certain things to do that they can help themselves. So typically, when Ministry of Health is asked by the public, what can they do? We use very commonsensical approach to say that observe good hygiene. If you are sick, see a doctor. Apply a mask when you are coughing, and wash your hands thoroughly. Simple things like that, and they appreciate very much because they then participate in this process of safeguarding themselves. Now, every outbreak is also an education moment. In peacetime, the public actually doesn't care much about public health. So all your messages during peacetime could be lost on the public. But when an emergency happens and it captures the fear and anxiety of the public, then they are very ready to listen, okay? And so you can use outbreaks as education moments, okay? So here was an outbreak of the food poisoning that had resulted in a death. And so we have asked this question through the media. So what else do we need to do? I go back to the original documentation on advancing health emergency preparedness in cities and urban settings. The health emergency preparedness for cities is not just the function of the health authority. Very often, there is also a local government and officials involved there, okay? So unless we are able to bring the message across to all the different stakeholders, the business community, the politician also very important, we are actually going to have a lot of challenges. So therefore, we must bring everyone on board. And here WHO has come up with further documentation, I believe is available on their website, on strengthening health emergency prevention, preparedness, response, and resilience. And all these actions should take place in peacetime. As I mentioned, when there is already a health emergency, it's not the time to build trust, okay? You need to build it in peacetime so that it can work smoothly during an emergency. And there are 5 C's here that are emphasized. The C's are involving coordination, collaborative surveillance, community protection, care that is safe and scalable, as well as countermeasures. So have a read of these documents. The WHO provides these for all countries to apply according to their own respective context. During the pandemic COVID, we had many hard lessons in urban epidemiology practice, and I had the privilege to work with the Lee Kuan Yew School of Public Policy to identify some of the trade-offs that had occurred as a result of the pandemic. So here I would like to share with you 5 of these trade-offs, okay? The first trade-off that we recognized was the equity versus equality. When the government announced a circuit breaker or movement control order or a lockdown, okay, the segment of the population that was adversely impacted was firstly the migrant worker population, but also the lower 1/5 of the Singapore society. Okay, because these are typically the households that depend on having to go out daily to find work. Otherwise, they have no income. There are also households that have to share, for example, computer. They may have one computer in the whole house. And when you have a lockdown, the Ministry of Education expects the children to study through the computer. And there are maybe 2 children or more, and the parents also want the computer. There will be problems that cause disruption. And indeed, we observe also a lot of mental health and dysfunction happen as a result of this type of problems. So when we make policy, we must always be aware of its impact, not just blanket across the whole population, but to certain vulnerable populations. As also with the migrant workforce in Singapore, we have over 1 million foreign workers. They stay in dormitories. We also recognize that there were inadequate sanitary facilities for all these workers. So in peacetime, it was all right, but when there was a transmission of a droplet-borne disease, there were too many workers per toilet that was available. So as a result of this pandemic, we have learned hard lessons. The dormitories have been reconfigured such that the ratio of numbers of persons to a toilet is now much, much better. Okay, a second trade-off that occurred during the pandemic was the argument for immediacy versus incrementalism. What is immediacy? I think if you saw the actions taken by many Western countries like Australia, UK, they had what was known as Freedom Day. On that day, they declared no more need to wear masks and so on. Singapore adopts a more incremental approach because we are a bit unsure of the consequences of such immediate measures. So there is merit in both approaches, but you must tailor it according to the situation. If there is something that is imminently dangerous, an immediate approach should be recommended because we are using the precautionary principle. Like, for example, the press release that alerted in the Bedok outbreak. But if you are unsure of the actions to be taken and the consequences to the public, then it may call for more prudence and therefore an incremental approach. So when we did our post-lockdown reopening of the economy, Singapore had to go through multiple phases. And in fact, it was like a dance, the hammer and the dance, where we opened a bit and then we realized we had opened too much, and then cases started to rise again. And then we had to go back a few steps and then try to reevaluate and implement new measures. So this was a very painful process, but we believe it's necessary. And the precautionary principle is always the principle upon which we apply. Trade-off number 3 is responsiveness versus responsibility. Contrary to what people think, there is a limited staff in public health work. And when our officer is undergoing contact tracing, for example, there are members of the public who call up to demand updates on their very unique situations. And this is unhelpful because the officer has to race against time to identify all the close contacts to institute quarantine measures. So responsiveness requires us in the public service to have maybe 24-hour period to respond to email, to phone query from members of the public. But in an emergency, I think responsibility to contain an outbreak and break the chain of transmission is much more important than responsiveness. And it's the same officer. So it is important to emphasize to them the important measures require responsibility are more important than urgent measures which require responsiveness. Trade-off number 4 is safety versus security. It was quite amusing in Singapore that every time the Prime Minister announced that he was going to go on air at noon to say something important about the COVID pandemic, people did not stay on near the TV or YouTube to watch. Rather, they all rushed down to the provision shops to stock up because they assumed the worst. And this was observed in many countries around the world as well. Okay, so what I would like to identify here is the issue of safety versus security. They are not the same. You may think that, oh, to be safe is to be secure, but it's not true. In Singapore, many Singaporeans, they felt safe. That means they knew that they were not going to die, but they felt very insecure. So let me now define for you what is the difference between safety and security. Safety is freedom from danger. So they knew that the government had taken all the due diligence to protect them and prevent transmission through exposure. But security is actually not freedom from danger, but freedom from fear. And there was always a lot of fear because of the uncertainties, anxieties, and urgencies in this situation. So I would put it to you that as the public health authority, we need to address not just the safety issues, but we also have to address the security issues that permeate our society and communities. So unless we can do that, it is not possible to prevent panic buying and other irresponsible measures. And last but not least, our final trade-off was lives versus livelihoods. When we introduced the measures, we thought that there was going to be a quick fix. Within 3 months, the outbreak of COVID would be over like SARS. But to our horror, we learned that it did not go away. And so livelihoods were affected. And I think today, with these lessons learned, we must also consider the livelihoods of people when we institute public health measures. Because what is the point of protecting them, but then they have no money and no food? What can they do? Okay, so we need to consider very carefully all the hard lessons that have been learned in the pandemic. And we hope that the response to our next pandemic, the imminent disease acts that is mentioned by WHO, will be a much better, more reasoned approach. Okay, I'm the program director for the Singapore FETP, and we have a tiered program where we train public officers, okay, in many different agencies, some of which are not public health professionals, in the management of outbreaks. And at the highest level, okay, we have a foundational tier 1 training, we have intermediate tier 2 training, and we have advanced tier 3 training. At the highest level, which is tier 3, we also have a core of officers, medical officers, known as the Epidemic Intelligence Service officers, okay? And these are professional and technical leadership officers, okay, that must understand about disease surveillance and control. And they must be able to improve the quality of field investigations for preparedness and response to health emergencies. So we put a lot of emphasis on building their skills and mentoring them, okay, so that they are able to undertake rapid response on the ground, apply the evidence-based holistic approach, as well as be able to communicate transmission dynamics in an effective way. So I summarize here. I'm coming to an end here soon. When you ask the first 3 questions, which I identified just now, the A, assess the situation, you are putting the data that we get in the community in context, okay? And so with the who, where, when, person, place, time, we are able to convert the data into information so that we can become well-informed. That's not good enough. We move up this ladder. My EIS officers have then to ask the next 2 questions, the why and how, and this will help them to understand the context. So from description, they now go to analysis, okay? And once they are able to understand the cause, they become knowledgeable. So it is different from being well-informed. Well-informed just knows who are the vulnerable out there. But knowledgeable means not just knowing who are the vulnerable, but also what you can do, okay? What is the cause of their vulnerability? And the last 3 questions we ask are in the realm of interventions. Okay, so what now are very important so that we can apply the knowledge to control measures. And from knowledge, then we create what we know as insight. So it's important to be informed, but it's also more important to be knowledgeable, and it's extremely important to be insightful. So your lessons begin at the base with the data, but we hope that everyone, especially those of you who are undertaking field epidemiology practice, will be able to be insightful officers on the ground. Okay, here I had the privilege to go to Tokyo with my colleague to conduct a next-gen FETP course for the local government officials from Sapporo, Osaka, and Tokyo early this year. We also had visitors in Singapore, and here we have the FETP trainees from Hong Kong and Brunei who were in Singapore also to attach to us for some of their experiences. And here we have our first next-gen FETP international course, which was held in Singapore last year. So we welcome partners to develop the next-gen FETP jointly with us. And we also welcome Universitas Gadjah Mada to be one of these partners to join us in creative ways to improve global health capacities and workforce quality. So you've heard about genomics. We are here a bit more basic. We don't just do genomics, we do comics as well. And we are actually in the business of trying to get our millennials, Gen Y and the Gen Z, which are entering the workforce, interested in public health. And I think this generation is much more easily approached if we can entertain them. So our next gen FETP is a form of edutainment, okay, program for them. And here are some of feedbacks from participants when we applied our international course in last year. Okay, so what can we build together? Let us advance collaborative next-gen initiatives. And over here, I end my talk. Thank you very much.
Thank you very much, Dr. Stephen. It is a good presentation and nice presentation about urban emergency and advancing the role of field epidemiology. Okay, so now we will go to the question and ask session, the discussion session. Is there anyone from the participant that want to directly ask a question to Dr. Stephen? If you want to ask something, you can just use the raise hand feature, and then I will unmute. You can ask in English, or if you are not confident, then you can ask using bahasa, and then I will try to translate.
Dr. Bayu, I think there are some question in the chat.
Oh yes, I think there is one question from Pak Tommy. Okay. Oh, we have one question from the audience. Okay, this is let me greet first for this one question, and then we will go to the question in chat. Okay, so the first one will be Pak Francis Tepu, and then next will be Dr. Risalia Reni Arisanti. Okay, first one, Pak Franz, can you introduce yourself and then you can ask your question.
Okay, so
okay, thank you, Pak Bayu.
Yeah. Hi.
Can you hear my voice?
Yes, we can hear you.
Okay, thank you. Congratulations for you, Pak Stephen, for your great lecture. Yeah, I do really agree with your presentation about urban epidemiology, especially how we conduct surveillance and also how to strengthen our capacity in level area in field. Yeah. I just want to hear from you about we have totally different between Singapore and Indonesia. I think Singapore is a city state, right? So it is will be more effective if we conduct surveillance from top to the bottom level. But in Indonesia, we have more than 70,000 islands and many cities in our country. So the difference is how uh, how to conduct the surveillance from one city to other city and how to build the communication. It will be more challenging, I think. In your opinion or based your experience, what we should do to build the urban epidemiology more effective, more yeah, to build our capacity also. Thank you.
Thank you very
Thank
much,
you, Pak
Pak
Franz.
Franz. Yes. Pak Franz and I, we met in Thailand last year. We had this privilege of being there together, so we know each other well. Yes, I think this is very relevant. What I have shared today is more about urban epidemiology practice, perhaps can be applied to your major city centers. And I think what we highlight is that there is a need to engage the local government officials, which may not be public health officials, because sometimes if we do not do this early enough, the obstacle is at the town council level, where there is objection to some of the things that we advise. Now, for the more other settings in Indonesia, which is a very large country, I would say that some of the principles in public health that are still applicable is firstly, collaboration. I think many of the township, many of the more rural setting, the sources of information that are available there may require collaborative surveillance, not necessarily through the official reporting system, but through other networks that are available in these communities. And I think involving the village or municipal heads are very important. So I think there is a need for commitment at the political level, at least, to get their buy-in for the measures that are going to help public health. So these things, I think, require a little bit of persuasion, and we have to do during peacetime. One important tool that the WHO has recently come out to help us promote this collaborative surveillance is the One Health framework. And if we go to the WHO website, we can see a series of documents just released this year on the competencies on One Health field epidemiology framework. And I think with this, we can train our officers on the ground in different contexts to be able to be effective for their own unique circumstances. I hope this answers Pak Franz.
One more
Franz?
question, may
Okay.
I? Yeah.
Yes, you can.
Okay, thank you. I'm interested with your the last presentation about next gen. Is it a workshop or a training or something like that? Maybe yeah. Can I be one of the participation of this kind of workshop? Thank you.
I think most certainly, we encourage, in fact, our different FETPs in the region to work with us to learn some of the principles of this next-gen FETP. What is the difference between next-gen FETP and the original formal FETP? The original formal one is a 2-year program that has a very specific targets curriculum to be covered in the short period of time. What we realized in Singapore is that many of our officer, good officer, but got no time, and they have too much other distraction in the process. So we have decided not to put in a 2-year restriction to their training. We have given each officer their own personalized training program. And I think one analogy I can use for all of you is that you all have played with Lego bricks before. Lego is this children's toy that you can make into many different creations. Some people can make motor car, some people can make an aeroplane, some can make a house. So it's the same for FETP Next Gen. We encourage the organization that is the employer for these trainees to tell us what do they want of their trainees. So in other words, is it a car, is it a house, or is it a plane? When they say they want it this way and it must be this size and this color, we work backwards to find the curriculum that meets their need. So I have experience with 16 public agencies in Singapore. Example is the Singapore Food Agency, the Ministry of Manpower, the National Parks Board. These are not public health people. They are administrator, they are local government officials, but they also want to learn about public health, especially in COVID period. So we have to tailor our FETP training to suit their need and not push them into areas where they do not see any purpose. So this is the concept. And I will need a little bit more, I think, time if we want to roll out a next-gen FETP to demonstrate to all of you. So I guess working with Gajah Mada may be a good idea in the future.
Okay, thank you, Dr. Stephen. So, Pak Frans, do you have any further question? Okay, thank you, Pak Frans. Next, so we will have Dr. Santi. You can please first introduce yourself and then you can ask your question. We cannot hear you. Your voice is...
Hear my voice now?
Yes, yes, we can hear now.
Yeah. Thank you so much, Dr. Stephen, for your great lecture. And I'm just curious because you mentioned several times that the outbreak come from the migrant workers and the other one is hawker place. Any special intervention on them that government of Singapore do with them to minimize the potential infection from those two vulnerable population, and then the other one as transit country. We know that Singapore it's transit country from other countries. That any special intervention from government of Singapore to do the let's say migration surveillance on this to minimize the infection from other countries, especially if we know that in those countries have special attention. Let's say maybe if Malaysia or maybe as Thai as a border, it's have or maybe Indonesia have maybe any notification or something, because we know that Malaysia and Singapore mobilization is high every single day, maybe more than 1,000 people come and out from Singapore. So there is any special intervention on it, because I think it's our the lesson from the transit country. It's also important for us. Thank you.
Thank you, Dr. Risalia. We have many concerns related to the transit populations, because Singapore is also a major transit center. Our Changi Airport has many, for example, from Indonesia on the way to the Middle East for Hajj, they fly through. So we are also concerned with the safety and health of these individuals. I think we cannot have broad-based blanket measures, but the key is that we must be very vigilant and understand the epidemiology of a specific exotic infection that can be associated with each vulnerable population. So I think some of the measures that we have learned the hard way with migrant workforce, for example, in Singapore, is that the dormitories, because of the need to share so many of the common washroom facilities, it was not satisfactory, okay, to prevent prevent transmission. Even though you keep cleaning, but there's so many people using, it would not be possible. So we have reduced the ratio of guest workers to the number of washrooms available, and we are also looking into wastewater surveillance, which may give us some basis for early detection of certain pathogens of interest. So we have tried wastewater surveillance for COVID and even Zika, and we see that there is potential in these new technologies that can perhaps in future be applied routinely to step up our early detection processes. Okay, so I think some of these are still not fully evaluated, but we are trying to keep an open mind to be creative to identify what are the modalities that we can apply for each disease, which is unique in itself. Okay.
Thank you for the question, but Santi, your voice is not up.
It's great news that Gajah Mada also have special partnership with the National University of Singapore to apply the wastewater surveillance, I think. So yeah, great to have a partnership on this. Thank you so much.
Thank you.
Yeah.
Thank you, Dr. Santi. Okay. Next, we are going to first to the chat room about there is a 2 question, and then we'll go to the next participant that are already raising hands. So for Pak Jusli, wait a moment. Okay, so in chat room we have 2 questions. The first one is from Pak Tumiat. What are the obstacles related to the investigation of outbreak in urban settings, and what is the solution that's already carried out?
Okay. If we think about people living in urban settings and compare them to people living in kampong setting, I think you realize that the level of friendliness and cooperation in a kampong setting is much better. So this has been confirmed by my colleagues also, for example, from Thailand. When they had dengue outbreak in Bangkok, they tried to undertake this door-to-door public health approach. And they said that most of the people living in these houses, they just slam the door in the face of the public health officer. So they are unable to communicate across in urban settings. So I think the obstacles we face in outbreak management in urban is a more difficult population. We have also in urban setting a lot of economic concerns. So there are very powerful stakeholders out there that may oppose the public health. Then we have also politicians involved. If we do not have their commitment, then we may find that we are not effective in the management of the outbreaks. I think because urban settings are also involving very large populations, with large populations will come a lot of different opinions and in fact, contrary opinions. So everything you do, you will find someone opposing you and disagreeing with your measures, you know, and that will add to the problem. And on top of that, we have social media. The people in the urban setting are very good, skillful in using social media, and they can access information that is not correct, and they can then use it to fight you. So all these are the obstacles that we are trying to upskill our officers to handle complex urban outbreaks.
Thank you, Dr. Stephen, for the explanation. I think it's quite similar with the one that we experience in big cities or city like Yogyakarta city. And we have like difficult situation if we go door to door to conduct investigation. Mostly they will refuse. Okay, and then next question from the chat room before we go to Pak Jusli is from Sylvia Kusrina. Oh, this is one of our alumni. We have the question is about awards, and we have awards to detect alert for outbreak, but not all of the frontline health facilities surveillance staff properly respond to this. Is there any suggestion to improve the sensitivity for the awards and the respond. And then about the, oh, it's about the comic, the Epi Force. Is there any way to access the comic from the presentation? Okay, thank you.
Okay, the easy answer first about the Epi. It's not ready yet, okay? We are incubating, okay? We are developing ideas. And in fact, I'm working with the WHO Academy to find a way to promote next-gen FETP for the world. And I think one of the avenues we will use is this comic, okay? There are also other ideas that we have. But once all these are ready, it will be made available to the whole world. Okay, so don't worry. I think you will see the comic one day. Now, the more difficult one is about this EWAs and how to detect and get your staff, properly responding to these alerts. I think everyone is very busy, especially in urban settings, and we all have very limited time. So I think we have to be realistic. And one of the things in Singapore that we are known for is to be very realistic. So in practice, we will accept the staff levels that they can support where they are, and we cannot demand more. So we ask and we try to configure our surveillance approach in a way that is doable by the different agencies. And an important observation which I can share with you is that if you have friends in these other agencies, and if you have a certain relationship with these staff, you will be surprised that they will be prepared to do a lot more for you. So in a way, I think it goes back again to trust building and relationship building. And we try to practice what we call win-win. In other words, I share this with you is not to make you do more work. I share this with you so that it improves your workflow and you will also benefit. And when we have this type of arrangement, I think we can get a lot more cooperation. I hope this answers your question.
Stephen, hopefully that's sort of the question from Sylvia and Tommy. Okay, next is from Pak Jusli Lakapu. He's also one of the alumni of FETP. Okay, Pak Jusli, could you introduce yourself and then ask the question?
Thank you. I'm Jusli Lakapu. Thank you for the time that given to me. I was graduated from University of Indonesia, FETP 2014. My question, because now I work in health quarantine. So my question relating to how the quarantine process in Changi Airport. We know that Changi Airport is the one of the business airport in the world. So there are many risk factor or many opportunity of infectious disease to come in through Changi Airport. So as one of FETP role, what are you doing, or maybe government do in the airport, Changi Airport, to prevent the infectious disease? And the second question is, what is the sanction given by government to the population or people who don't obey the regulation? For example, if like food poisoning happen and it is caused by the people there, what is the sanction from government given to them? And the last question is, can you share your material after this for us? Thank you. Thank you, Pak Bayu.
Thank you.
Pak Jusli.
Yes. Okay. The first one about Changi Airport. I think your concern is about the importation of emerging infectious diseases. In the past, the IHR required the airport must have a quarantine facility for yellow fever, in case there is someone without a valid vaccination certificate coming into the country, then they will be subject to this quarantine process at the airport before being allowed to enter the country. I think many countries have this practice. But in real life, very few of these are implemented. Okay, so I'm not aware of Singapore Changi Airport ever having to quarantine anyone at the airport itself for purposes of yellow fever. Now, of greater concern is that if someone falls sick on board a plane flight coming into Singapore and it looks suspicious like infectious disease, could be Ebola, hemorrhagic fever or something like that, then what is the process? Okay, we have run many exercises, okay, with the Changi Airport and the Public Health Authority to have this process where the medical clinic at the airport will work with the Public Health Authority to secure the patient on board the plane once it lands, okay, into what we call a HLIU, High Level Isolation Unit ambulance. Okay, so this is like a bubble, you know. They come in, they go into this HLIU ambulance. It is directly transported from the airport to the National Center for Infectious Disease, where it will be received. It will be taken up into a isolation room. Okay, we have a special premises for this where they will be investigated without any risk of exposure to other parts of the community. So this is something that we have put in place, but we have not, thankfully, we have not had to use this process. Okay. This is different from the home quarantine order, which is a quarantine of people suspected to be exposed to close contact of dangerous infectious disease. So the home quarantine order has been a legislative process which the Singapore Parliament has approved for certain diseases. And you had asked about what are the enforcement action. In the law, there is an avenue to jail such a person if they do not comply. So if, for example, someone disobeys, okay, mask wearing or refuse to be quarantined, the law can fine the person and even jail the person. All right. Now, during the COVID pandemic, there were many instances where we had foreigners also who give false information. So we had people who, during contact tracing, did not give proper information for their own reasons, and later discovered by the Ministry of Health that they had lied to the public officer. Okay, so these people, in fact, were later prosecuted and also jailed in Singapore. All right, so we have been tough on people who disobey the law because we want to show that we are serious about enforcement and compliance. There were also foreigners who refused to do safe distancing during the COVID, and there were a notable number of expatriates who had gone to a pub when they were told that they cannot go to a pub, and they had many drinks, and as a result, the government repatriated them. That means they could no longer work in Singapore. They lost their work employment pass, and they were sent back to their home country. So this is the government showing that we are very serious about the measures that we put in place. Okay. Now, I think there was one question about the slides. Yes, I will provide the slides PDF for to be shared with Dr. Bayu.
Okay, thank you very much, Dr. Stephen. Okay. Okay, next we already have another participant that want to ask question. Okay, but Dwi Rizky Ananda, please introduce yourself first and then you can ask question.
Terima kasih Pak Bayu. Selamat siang Pak Bayu, and then selamat siang Dr. Stephen. Hello, my name is Dwi. I'm currently undergoing traineeship in my second semester in Universitas Gadjah Mada. I would like to ask the question, are there any tips for writing writing the analysis of the case with a small number of cases where the case control analysis are not able to be performed and the source of transmission is difficult to determine, so that the dissemination that will be clearly understood by the population? And what part of the investigation that we should focus on when it comes to disseminate the report so that our voice will be clearly heard by the population and also the stakeholder. And also one question from my side friends. He asked that, are there any outbreak happen in Singapore from vaccine preventable disease such as pertussis or diphtheria happen in Singapore? Because it's not mentioned from your slide before. Thank you for the opportunity.
Thank you, Badri.
Sorry, can you repeat the second question, please?
The second question is that, are there any outbreak happen in Singapore from vaccine preventable disease such as pertussis or diphtheria or etc. that happen in Singapore? Because it's not mentioned in your slide before.
Okay. I will answer the second one first. It's quite easy. Yes, we do have small clusters of cases of measles, but investigation showed that these are actually imported cases mainly. And we do maintain a very high vaccination rate in our school children. So fortunately for us, we have not had any local outbreaks of vaccine preventable disease. Okay. Now, for the writing of small outbreaks, I think it depends on what context. And I have usually 3 dialects to speak about, okay? The communication that you want to write up on, is it for administrators, is it for members of the public, or is it for the scientific community? And these 3 are very different dialects, okay? So when my officers, when they work in the ministry, one important factor is that they must be able to communicate with their senior management and administrators. And so they have to speak a certain language that is more policy related, okay? And for members of the public, it is about prevention and control and what is being done, what to expect and what they can do about it. And that is slightly different. And again, when we want to write for a scientific publication, then we have to follow what is a peer review process, and we must have proper introduction. We must have the proper methodology and the discussion. Okay. So for all this, I think it depends on what you want with your little project now that you are having it, and maybe one of the that you want to consider is discuss with your supervisor what you can get out of this. Okay, and I showed you in my cholera outbreak, no finding is also a finding. So it could be something very unusual. You could develop a protocol for small outbreak investigation, and that itself is a very useful tool because there are many outbreaks that do not lend themselves well to the analytical case control process. Okay.
Thank you,
Do you
Dr.
have
Steven.
further question? Any further question, Badri?
And no, enough, Pak Bayu. Thank you, Pak Bayu.
Okay. Thank you, Badri. Okay. Oh, we have another question. Oh, from Dr. Santi. Singapore is also known for the large number of elderly population. Is there any special outbreaks or any outbreaks that occurs for this age group for those with elderly? And how is, if there is any, is how the approach was taken?
Okay, Singapore is aging fast, and I think with this demographic, there will be increasing vulnerability to certain infections. But there is no special outbreak that involve only the elderly. But any infectious disease, okay, that has epidemic potential can affect this group disproportionately. So we need to be concerned with the increased susceptibility of the elderly, and therefore some things that came to mind, for example, in my past experience, there was one year where we had very unusual rainfall, and as a result, there were flooding in different parts of Singapore. And in the process, about a month or 2 after the flooding, we saw a number of cases involving the elderly coming down with pneumonic melioidosis. Okay, so this is Burkholderia pseudomyeli, is an environmental organism found in the soil. We think that the flood may have brought up the water table and so pushed the organism to the surface, and then with cars and the road conditions, there may be aerosolization of these Burkholderia organisms, and it was inhaled by the passerbys. I think that normally healthy person may not have come down with symptoms, but there were quite a few elderly that seem to show symptoms. So this could be an alert for us of things to come when we have an aging population.
Okay, Dr. Stephen. So that is, yeah, we all agree that aging populations, especially elderly, they have their immune response is decreasing. So, okay, is there any other questions? One question maybe from the participants. Okay, it looks like no further questions. Okay, so thank you, Dr. Stephen.
Dr.
For
Bayu,
the...
I think there's a
Yes?
question from
Oh, Pak
the-
Yusuf. Okay, this is last minute question. Okay, no problem. Okay, from Mas Yusuf Maulana. How to engage stakeholders to participate in this communication and how to handle rumors in Singapore?
I think this is more art than science to engage stakeholders. I give you example. For example, we had outbreaks in school where the school principal is not cooperative and he's a stakeholder. Maybe he did not want the public health to be involved in case it's embarrassing to the school. So he was not cooperative, but we had to convince him, and we approached it like this. We said that we in the ministry are not here to embarrass you. We are here to investigate, to find the truth, which we will share with you so that you can improve and prevent an outbreak from happening again. Now, when it comes to media, we will back you up if you cooperate with us. But if you do not cooperate with us, when the media come to you, we will not be helping you. So with this kind of approach where we can bring the stakeholder to the same side as the public health official, then I think that is a reasonable approach to engage stakeholder in the risk communication. So this is how we do that. And then in terms of rumors, there will always be rumors with social media. So we will have to now see how much effort we can spend to handle these rumors. But typically, what we do in peacetime is that we build up our own credibility first. In other words, you must become the trusted source of information for the public so that when rumors happen, you can dismiss it and the public will still believe you. So how you become a credible source, you must have a relationship with the stakeholders. You must also have a credible, you must also be authentic, reliable, and have empathy for the public. So all these are part of the art of public health when we practice it. Okay.
Yes, I agree that engaging stakeholders is one of the arts of field epidemiology, because in the training program, most of the time, trainee will involved in the engaging stakeholders, especially during outbreaks. And I think Yusuf is one of our alumni from the field epidemiology training program. Okay, so we are already in the end of the guest lecture. And so before I forget something, it's related with the wastewater surveillance. In our departments, we are currently exploring and creating we have a project about wastewater surveillance managing by one of our assistant professor, which is also our head of department in epidemiology and also lecturer in field epidemiology training program. Maybe we can arrange sometimes for Dr. Stephen and Dr. Vika from our departments to have a conversation regarding this wastewater surveillance that currently being developed in Indonesia. And then it'll be quite interesting also if we can have a further communication and collaboration regarding the urban field epidemiology. And because as we know that in Yogyakarta district, Yogyakarta city, it's typically an urban area, and that similar with Singapore. Okay, I think we are entering the last section, which is a summary. Thank you, Dr. Stephen, for the interesting lecture and discussion. From this discussion and lecture today, we can see that urban cities is an important location, because in every country we will have an urban area, especially of at least in the capital city and the others. Like for example, in Indonesia, it's a capital city for the Indonesia, and for each province, it's usually an urban area. So that it's quite important to have the different perspective of urban epidemiology. And then also, we also talk, Dr. Stephen also give us the 3 simplified methods for epidemic investigation, which is ABC. It's similar with the one in medical about the emergency. But in the medical, we say airway, breathing, and then circulation. In epidemiology, we call it ABC. It's for the A for the assess the situation, epidemiology descriptive, and then B, break the chain of transmission, which is the analytical epidemiology. And then C for the communicate the findings. It's for the communication after we find the findings to prevent and create appropriate disease control with the stakeholders.
Intervention.
And then, yes, is it interventional IP. And then we also need to work with moral ground and integrity. And there is a several trade-offs that we need to consider when there is an outbreak, epidemic, or pandemic in the future. For example, like immediacy or the incremental, or another thing is safety versus security. And last but not least, we hope that this collaboration and cooperation it can be improved in the future, when we will have another collaboration, for example, like open epidemiology workshop involving the trainee and the others lecturer from the field epidemiology training program in UGM. Hopefully, we can invite Dr. Stephen to our place. Okay, I think that's all from me. Dr. Stephen, you have 1 or 2 words for your closing remarks.
I think I've spoken a lot. I really encourage all of you to keep going, because you are doing good work, and you must have the passion to serve the public. And I think in the end, we will get there. All right. So terima kasih. Jumpa lagi.
Okay, thank you, Dr. Stephen. We will meet again in the future. Hopefully, we will have close contact after this to collaborate regarding the urban epidemiology. Okay, I think that's all from me, and then this is the final, the closure for this seminar. And then thank you for Dr. Stephen for your time to give us lecture that give us an eye-opener that urban epidemiology is important, and there is a different way to approach this epidemiology. And then, so thank you also for all of the participants for your engagement, and then for your participation in this Wednesday seminar or guest lecture. My name is Bayu Satria Pratama, and I close this Wednesday seminar. Thank you, and good afternoon, and stay healthy for everyone.
Bye-bye.
Thank you. Bye-bye, Dr. Stephen.